Thank you for joining today for my presentation. And, I was really honored that Dan invited me to speak after Dr. Hendricks referred me to your group. So the topic that I'll be talking about today is a modification of a presentation that I've given a couple other times. And in this presentation, I really want to focus on the ethical considerations and power dynamics specific to psychedelic therapy. So my name is Rafaelle Lancelotta. I use they, she pronouns. I'm a PhD student at the Ohio State University, and I work at the Center for Psychedelic Drug Research and Education lab. I also am a founding board member at the Source Research Foundation, which is a nonprofit grant-making organization that's existed since 2017. And we award grants to students, community members, and we also have a separate grant program for people who are wanting to attend psychedelic conferences. I'm also the administrator and moderator of 5-MeO-DMT.org, which is a harm reduction forum for 5-MeO-DMT. And I also provide some consulting and integration support via my website, relationshipispsychedelic.com. And we will also be joined by my cat, Helix, for this presentation. So just, here's just the team that I work with here at Ohio. Just really lucky to work with these folks, and I get to be here and present with all of you. So as we were talking about, this last spring, there's been so much controversy coming up around psychedelic therapy and the potential for abuse. And we're seeing all these headlines that look a lot like these. And it's raising a lot of questions about ethics and, how do ethics play in with psychedelic therapy? And one of the things that, for those who are more clinically trained or have, experience working in clinical settings, these ethical problems are not new. These are ethical problems I'm sure you've talked about. These are certain variations of themes that you've heard in your accredited coursework. However, with psychedelics, we're in this interesting gray area where it's not clear who's delivering the services. There's a lot of demand for the services, and there are people who may not be fully qualified, may not have actually had the ethical training that a credentialed licensed clinician may have had. And so they're operating in these sort of gray areas, and they may be unaware of the dynamics that are at play. In addition, even licensed clinicians are operating in gray areas. And so it sort of increases the need to be critical and to ask questions. So that's what I'm hoping to talk about with all of you today. And hopefully, I want to offer some questions, but I also am hoping to offer some answers as well. I don't want to just, outline what the problems are. I want to offer some solutions and hopefully some points for collaboration going forward. So how does this happen? One basic way that I've been conceptualizing this is that we're currently experiencing this relationship between access and power and privilege and abuse, right? And so there's this desire for access to these interventions and therapies. There are privileged and powerful people who have access to these modalities, whether it's through training, whether it's through personal experience, or whether that is through, actually having, access to substances. And then, with that access and power, there's this great potential for abuse, which is where that power and privilege and access are used in ways that essentially, take advantage of people in vulnerable positions. So just something to introduce the mechanisms of how this may be playing out. So just to further define some things here, like, in the Agency for Healthcare Research and Quality, they talk about access to healthcare having 4 main components, and those are coverage, services, timeliness, and workforce. And as we talk about coverage, for example, it's like, how well are people able to access this through the healthcare system? Having services available. And so there's, in lots of the healthcare spaces, you have a usual source of care. You have some place that people can plug in to receive those services that they need. Then we also have the piece of timeliness. So people are able to receive the healthcare at an appropriate time and not years or months after the fact. And finally, it needs to have a good workforce. It needs to have people who are capable, qualified, and culturally competent in order to provide the services that are needed by the client base. But we're facing problems of access because right now there isn't a lot of mental health coverage in this country. Holistic mental health care and the definition of holistic mental health care can be done in many ways. The way that I would approach it in this presentation and in this context is essentially mental health care that takes into account the whole of the person. So we're looking at the physical health, we're looking at access to not just a therapist, but perhaps also having access to a psychiatrist, perhaps access to other professionals like a dietitian, for example, that can provide a range of services that are going to help people achieve wellness. Right now, insurance primarily covers brief and solution-focused interventions. Hi, yes, that is true. And so because of these limitations with insurance, and also the fact that not everyone has insurance, really creates a deficit in that coverage. Then we have a lack of services. So there's not a ton of adequate screening and referral networks for all these different levels of care. And I don't think that levels of care are properly and fully defined in our mental health care system, in terms of where people come in and where they get connected to services. Timeliness, again, we don't really have a well-defined system where people are, referred to services at the appropriate times, and it can be difficult to connect people to those services when they need them. So when we insert psychedelic therapy into that system, psychedelic therapy is sort of being turned around and you're trying to stick it into pieces of the puzzle where it may not actually fit. And so seeing psychedelic therapy as like a crisis intervention, it's still not something that we have the evidence necessary in order to know how and why psychedelics may help at certain stages of someone's healing. And finally, we have a major deficit in competent providers. Given that the research into psychedelic therapy is limited and has, small sample sizes, and really does need to be researched more thoroughly before we have any sort of standards. There are people doing trainings, but at the same time, those trainings are based off of assumptions and not necessarily based off of, generalizable evidence-based treatment. So as a result, we don't really have a standard for treatment, and we have a huge dearth of competent providers that can provide this sort of thing. So then we enter into the space of abuse. So some things that can be viewed as abuse is the imposition of reality on another person, the violation of boundaries, taking advantage of vulnerability. So, this can include clinical populations. Just having a mental health condition is a vulnerability to begin with. But there's another layer of vulnerability, which is when people are uneducated about psychedelics, they enter into another layer of power dynamic where, a therapist or a facilitator is, now not only are they, the educated mental health person, but now they also know more about, psychedelics and how they work. And that's a whole other body of information that, complicates the power dynamic. So the lack of education about psychedelics, and then also the inexperience with psychedelics. If you have someone approaching a clinician who has never experienced psychedelics before, that's another layer of vulnerability that, this person is going to be looking to the therapist or facilitator to essentially curate, an altered state experience that, is so personal and so unique to each individual, that really puts that person in a really vulnerable place. And then finally, there's the operating outside a scope of competence. And it's arguable that a lot of people are operating outside a scope of competence because there aren't tons of experiences to prepare people to say, this is within my scope. And, and I don't think that there has been an agreed upon, experience that really we can say, okay, this is a gold standard for, being prepared to provide this to people. So it's not to say that, that everybody's outside their scope of competence, but I think it's just to introduce more critical thinking about who is competent and how do we define scope of competence in this field. So we can also, I want to go on to talk about, specifically in psychedelic therapy, some of the potentials for abuse, and we can even go a bit further into some of these, but I kind of break them down into 4 different areas that in some ways overlap and inform one another, but they are costs, blaming, bypassing, and the creation of a guru dynamic. So in terms of costs, there's a big demand for this type of intervention and this type of therapy. So it's very easy for somebody who's educating a new person to overstate the benefits, for someone not to educate their clients about what the limitations may be or what the limitations are. And it's very easy to charge large sums of money because there aren't as many people that are prepared to do this kind of work. Another problem that can happen is, especially with people who see psychedelics as this near miraculous treatment, there is a tendency to potentially blame clients for, not doing it right, or not working hard enough, or having some sort of fault that's preventing them from getting the benefits of this type of intervention. So this also brings in more of that individual focus rather than understanding the circumstance and the context of the client or the patient. And that blaming and putting the blame on the individual can further create problems in, the person's journey of healing. Another potential issue is, potentially either facilitating or contributing to the bypass of lived experience. So, this can happen with clinicians who treat the altered state as the exact mode of change rather than as a potential catalyst. So when you have a clinician who is seeing, this altered state as being something that is doing something to the client, or is something that is, creating this, creating the change, then that can actually bypass a lot of what's happening in the here and now, what's happening in the actual reality of that client and the reality of their life. And so if the therapist is not also anchored in the here and now and anchored in the context of those individuals, then it essentially can really facilitate this sort of bypass of, well, I felt all these big emotions and therefore like they should be gone now, when really, if there are situations in that person's life that continue to trigger those responses, then those emotions are going to persist regardless of how much catharsis there can be experienced. And then finally, just adding on to that power dynamic that we talked about in the last slide, is that there's this creation and utilizing of treatment models without adequate empirical evidence. So there are therapists or there are facilitators who may be offering certain models or certain ways of doing therapy that that they think are best or they think will work, without really having a solid foundation in research or a solid foundation in any sort of history of practice. I think the use of psychedelics in the modern Western medical understanding of mental illness is quite new. And so when there is this lack of understanding of the context in which these interventions are being done, it can create this dynamic where the therapist who has potentially created the modality or created the treatment model, they're in a position of overconfidence. So whether they're trusting that this drug is going to do a certain thing, or they're overconfident in the model that they're using, or they have an overconfidence in their ability to deliver the results that they are proposing, it really increases that power dynamic, and it puts the therapist in a position where not only do they have a lot of privilege in terms of having lots of knowledge and lots of skills, it really puts them in a position where the therapist can't be wrong. And for those who are familiar with therapy, a big part of therapy is for clients to be able to engage with therapists when the therapist is wrong. When the therapist has made a mistake, that it needs to be a collaborative process, and that can be a really big part of healing. So I want to offer this case example to help digest and hopefully give a backdrop for these different dynamics that I've been describing. So just take a moment and imagine that you are a new, independently licensed mental health clinician, and you just completed a ketamine-assisted psychotherapy training. You've spent over $10,000 to get the required training, licensing hours, and experience you need to legally provide the services you want to offer. You're struggling to afford your living expenses 1 month to the next, and you're trying to expand your caseload and take on more CAP clients. So a client reaches out to you saying that they've been reading about psychedelics and how they can help cure mental health conditions. They tell you that they don't have much income, they're working 2 jobs, and they don't have that much time for therapy, but they've been dealing with PTSD for the last 10 years and they're desperate for relief. So here's some proposed questions for you to ask yourself is, how do you know when or if you should refer out? Who are you referring to? How do you assess if this is an appropriate fit for your practice? How might you approach the conversation? And what ethical dilemmas are you running into? And I would love, since we don't have too many people here, I would really love to invite folks to participate and to share what thoughts you're having, in this scenario. What kinds of things are you thinking about? What comes to mind in this situation?
Would you mind backing up just to the previous slide just for a sec?
Yes, absolutely.
I definitely could say that I see some things that could go wrong here. There are 2 things that stick out to me. Firstly, the therapist in this case is under a lot of financial pressure. I don't know what their current caseload is. Maybe it's a lot, maybe it's already too much. Will they have the personal resources to take this patient on when they themselves are so stressed out, or will they be pushed to go beyond their limits? Another thing, this patient seems to have a more severe condition. They've been struggling for it for a long time. Expectations may be high, and the therapist may experience that transference of those expectations and may set themselves up to be a guru because they feel like a guru is needed, perhaps even from a well-intentioned place. But those are 2 things that stick out to me.
Yeah, thanks for pointing those things out. Yeah, I mean, there is like this great strain on the clinician, and I would argue that this situation for this clinician is probably quite common right now in this space, because these trainings are very expensive and you're really having to sell people on this idea that this is the type of therapy they need. And it does seem to attract people who, like you said, are think at this point a guru is what I need. I need to really be rescued from this situation. Yeah, great points.
I would say another red flag is that this person also does not have much time for therapy. And so I think there's sort of this belief in the space, and it's definitely because of all the hype that this is just like a Hail Mary kind of thing, that it's just like all else fails, like at least you have a psychedelic experience that can kind of lift you out of your suffering. But that's a false belief. I mean, it may offer temporary relief, but it doesn't solve the systemic sort of issues that are causing you to, continually feel that way. And so, yeah, I mean, there's just so much pressure on this moment around this decision coming from both the patient and the client. And that's potentially bad chemistry. So yeah, I don't know. I would definitely seek like consultation on that kind of situation, because that's a really hard one to make by yourself. And that's another thing is like, there's not like strong, like communal sort of resources. Like if you want support for making these kinds of decisions, they're not like institutions that provide that. It's just got to be like friends and colleagues that, hopefully have more experience, but we're all sort of just guessing, nobody really knows at this point. There are no experts on psychedelic therapy at this point.
There are experts on psychedelic therapy, but there are very few of them.
Yes.
And they're difficult to access, right? They're in high demand, they're difficult to access, and they, you know, they're not super accessible, right? For a clinician who is financially struggling, it may be really difficult for them to have access to, the kind of supervision they need long term, with a case like this, to make these kinds of decisions. Yeah. Right.
I have a comment. I'm sorry, I can't get my camera to turn on. I'm just wondering if, as a profession, there should be a mandatory set number of sessions that need to have a supervision built in. Once you spend that kind of money training, everybody has to begin somewhere, right? Regardless of the external circumstances of financial pressure, et cetera, on this therapist, somebody should help the therapist evaluate the patient appropriateness for this type of therapy, one. And two, if it's appropriate to provide ketamine therapy, in particular in this case, there should be live, potentially Zoom-based supervision during at least parts of the therapy or the post psychedelic experience therapy, so that, and again, it raises a question of whether or not the training programs are thinking kind of long-term in terms of success of this as a profession, and making sure that the people that they train, obviously as beginners starting out in the world, have adequate supervision and adequate competence. So it's a bigger question, I think, about how people are trained. And again, I'm ignorant about this, but talk about, if you would, is there any infrastructure? Sounds like there isn't. Infrastructure to support recent trainees. Again, any heart surgeon has to do their first valve replacement or their first bypass surgery somehow. It has to begin. We all understand that, and certainly it's important for the clinician to be upfront with the patient about that as well. I think that's part of being ethical. This is new for me. You're getting a reduced rate potentially because I'm a beginner. I'll be supervised closely by a senior practitioner, et cetera. So I think those are mandatory in this field, as well as anything else that you're training to do that involves a person's life or mental health.
Yeah, I agree. Thanks for raising that question. Yes, I think a lot of trainings that currently exist don't have as much of that component because they are particularly targeting independently licensed clinicians, meaning that they're clinicians who've already completed all of their, supervision hours, and they are able to work by themselves, and therefore they, receive a, psychedelic therapy training, but they don't have any sort of licensing requirement to have those supervised sessions, like you said. There are some training organizations that have some built-in supervision, but it's not a standard. And, I can say, like, in my experience, when I was a provisionally licensed counselor, I did all of my supervision hours at a ketamine-assisted therapy clinic. So, clients did pay, a rate, knowing that I was, in training, and that was the process. But the infrastructure that is required in order to support a new clinician and to supervise that new clinician is pretty significant. It does require a lot of resources in order to do so. I would say that right now, there's more emphasis on, okay, how do we get more people to receive the services, rather than focusing on how do we support new clinicians in the transition process to doing this kind of work, because it is resource intensive to properly train those clinicians.
Sure, but that seems very short-sighted, I think, you know?
I agree with you. That's why I'm here.
Yeah, exactly. So where do you begin with changing that, though, you know, in terms of how people are nurtured and trained? You know?
Yeah. Yeah.
What are the organizations that really need to create standards of care? You know, I'm a physician. We have that in healthcare. You know, there are well-known standards of care. There are requirements, both legal and professional and ethical, that one needs to meet. And obviously, this is a nascent field, and it's got a lot of ground to catch up with, because they're, you know, they're in the HOV lane, speeding ahead, and you know, they're making up the rules as they go.
Absolutely. Yeah. And I agree with you. I will talk about, you know, I will talk about some of my recommendations and some ideas and some potential solutions to going forward. So yeah, we will touch on that. Any other
Great.
folks that want to share their thoughts as they look at this case?
Just one more question. You know, in mental health, it's fields, apart from this, it's fairly common to pay for supervision, right? Is that an option that exists anywhere in the psychedelic field?
Yeah, I think that there are people in the psychedelic field that, you know, offer supervision that, you know, people can pay for. And I think a lot of times people are reluctant to pay for supervision because they're already in the hole from a super expensive training, and they sort of put all their eggs in that basket, not thinking like, oh, I'm going to need to continue investing for the next several years, because it's not just about getting the certificate, it's also about building, like you said, building that experience, right? So, you know, in this scenario, this person is kind of at the end of their rope. They don't have much money, but they do have the certification for ketamine therapy.
Mm-hmm. Well, again, I think, you know, with creative thinking, even without much money, you know, get a few people together for supervision sessions, and, you know, 4 times 50 is 200, and you get enough to pay a supervisor, you know, for group supervision sessions potentially. But anyway, go ahead. I don't want to hold you back from the rest of your talk.
No, absolutely. These are great points. I'm glad you're bringing them up. And, you know, as we move into this section where we address these problems, you know, it's not about the drugs in psychedelic therapy, it's the people. And so the solutions that I would offer, one of them actually being what I don't know your name, but KG is what it says on Zoom. You know, one of the things that you're suggesting is
It's Ken. Sorry,
Ken. So, you know, Ken, you know, you're suggesting ultimately that that it be collaborative, right? That this has to be a process that is collaborative. That, you know, if you're a clinician that's financially struggling, then it's important to collaborate with other clinicians who may be in a similar situation, and, you know, identify somebody who can offer some supervision or can offer some consultation, and, you know, approach that person and say, hey, you know, we want to meet with you to talk about our caseload. We want to talk about our decision making. We want to make sure that we're making the best decisions. You know, we are new to the field. We are still learning what we need to do. So, you know, I put here that it's evolving. It's important that psychedelic therapy recognizes that it's still in very early stages. And so if somebody's engaged in this type of work or this type of modality, it's important to, as part of that practice, to recognize that it's still very experimental and there's still so much that's being learned, you know, almost on a month-by-month basis. So it is important to know that things are really constantly being reworked, and it's important to really be thinking and being in dialogue with other professionals who are, close to the research and understanding like what are the new things that we're learning through this process. Like other therapy, it needs to be person-centered. So really prioritizing the client, the patient, and making sure that they have as much agency as possible as they can have in this process. And so, I think like Itamar was talking about the problems with, people who are looking for a guru, and the importance of the therapist of recognizing that transference and using that in a way to then return that power to the client and center the client back in the process, so that we can come back to this collaborative place. I also add here this idea of integrated, because these treatments they're not isolated. Mental health and the process of healing is connected to our bodies, it's connected to our relationships, it's connected to our communities. And so the process of therapy has to have all these things in consideration. And so again, that is more work for a clinician. A clinician doing psychedelic therapy can't just be the person that somebody talks to vent about their difficult week. It goes so much more beyond that, because now you're dealing with much more complex systems for those individuals. So I think, recognizing that that there needs to be an integrated collaborative process. And finally, there needs to be an element of sustainability. And, again, like this idea of, here's this clinician who has spent all their savings to get this certification, and, they have all the titles that they need in order to do this work, but now they can barely pay their rent, and they don't have a sustainable business model. They haven't created the, professional connections necessary in order to really be engaging in this process. So really approaching this from a sustainable way to figuring out, okay, how can I do this in a way that allows me to survive, and then also that allows me to consistently support people in their process. And then finally, that aspect of patience, that this is still so new, and there's still so much that we need to learn about all of this, these different drugs, these different treatments, and, how different aspects of them come together in order to be effective treatments. So, so these are some of the ideas and solutions that I would put forward in terms of how we can consider, more safe approaches going forward. So these are some questions that I've put together for people who are interested in psychedelics or interested in this field. Maybe people who are, aspiring psychedelic therapists, or maybe people who are already doing that work. Making sure that you're constantly checking in with these questions of, what are my intentions? Why am I here? Why am I doing what I'm doing? Thinking about the ways that you can cause harm, and also considering, how could harm come to you in the form of, grievance, or, a client that may not be prepared for this kind of work. Do you have the skills, training, and awareness to anticipate harms? I think also the question, do I actually know what I'm doing? I think, I think that we are always making our best guess. And I think that's why we talk about healthcare as a practice. I think that it is important to recognize that healthcare professionals are doing the best that they can, and healthcare professionals do make mistakes. I think that is important. And I think it's also important to recognize that the reason why people are licensed is that they are making decisions with reasonable margins of safety, where the mistakes that they make are not going to, ideally not going to be extremely detrimental to their clients. And so the mistakes that are made either can be corrected through conversation, where the client says, hey, you said this about me, and I don't think that applies, right? And for the therapist to say, oh, you know what, you're right, like I didn't mean it that way, or, please, educate me more about who you are, right? Like that was a mistake that I made. And that requires a certain level of experience to recognize, like, okay, what are the therapist biases that can get in the way? And finally, how do I know what I know? Really, I think that's sort of understanding where knowledge is coming from in this field and in trainings, and knowing that, because like when we really do ask that question, how do I know what I know? We can reflect that there is still a lot that is unknown. There's still more that needs to be understood. And then finally, like making sure that we have people who can and will hold you accountable, that aren't just you. And having these questions can help guide someone who has a great deal of a strong desire to help people and a strong calling towards this kind of work. And hopefully, these questions can help guide that person or those individuals to be able to practice in ways that are ethical and, can really be of maximum benefit to others. So yeah, I want to open up now to questions and discussion. This is I want it to be a kind of an open forum for folks. We still have a decent amount of time, so and yeah, this is definitely something that has a ton of nuance. So I think I'm more here for the conversations. I don't claim to have all the answers, but I'm hoping that by talking about this, we have more opportunities. So thank you.
I have to say, one of the things that I was thinking about, talking about minimizing the potential harms of psychedelic therapy. One of the reasons, like you said, it's seen as a crisis therapy right now. It's kind of the last line after your SSRIs have not helped, after goodness knows what has not helped a person. Most of the people coming now are actually pretty desperate. And sometimes I wonder, is there something to be said for good enough therapy? Is maybe the problem that we don't adequately manage expectations? We don't say, I'm not a guru, this is not going to solve all the problems. Maybe we are not going to do 5 high-dose sessions with ketamine. We're going to do 2 small ones with the time and money that both parties have available, and see what kind of aid that has. And maybe that will be a bridge to more, maybe it won't be. So is there maybe a place for scaling down and making a therapy a bit more appropriate? Is it more so what we're promising and how much we're trying to do as opposed to the therapy itself?
Yeah, I mean, I think that's a great point. Like, how can we ease into the process? How can we, as clinicians, how can we reduce some of the illusion of urgency and invite people into a place of like, okay, this is a process that we're entering into. We have these tools that can facilitate that process, but the tools are not the process. I think that's a great point.
Yeah, related to that, I think one of the times like that I look forward to most in this field is when these just become part of a therapist's toolkit rather than being like a thing that you explicitly go to a therapist for. Because to me, that's just not the right place of psychedelics in healing. It's just, if you're not also doing mindfulness and like exercise and like all these other things and like folding into a community, working through your relationships, a psychedelic is not going to solve those problems for you. It may be a start for some people, it may sort of open your eyes to like the sort of like the lights on the dashboard, so to speak, that in your life that maybe need some addressing, but just dosing again and again and again is not a solution to those problems. That's basically bypass, as you sort of underlined. And so like, I think to me, that's like a good trajectory for the field, is for the hype to kind of just die down and for this to just assume its position as nothing more special than any other kind of approach we have, but like a useful tool in some cases for some people. But I think it's really hard because there's so much attention on this right now that it just seems like there's something so exceptional. And in a sense there is, like, I'm not trying to say that like a psychedelic experience can't be incredibly powerful for someone, but like to assume that it's the thing, that's, I think, where it really starts to go wrong for people. Yeah, I don't know if you have any thoughts about that, but.
Yeah, I mean, I think that a psychedelic experience, like you said, can be incredibly powerful. And it also is going to be powerful depending on the context in which it's had, right? And so, like you said, in the context of really good therapy, that experience can be really powerful because you have that foundation of the therapeutic relationship and whatever other modalities, right? And I know, Dan, you said you're interested in somatic work. So, having that foundation and doing some somatic work outside of psychedelics can really be a great foundation for when somebody has a psychedelic experience in the context of a relationship where, we've done this sober, we have learned how to be in relationship with our bodies, and the psychedelics enhance and amplify those processes. And that's where there can be so much benefit for something like this. Whereas, when that's not there, and we only have a psychedelic, then, somebody can, like you said, they can sort of see these lights on the dashboard, but then there's some disconnection in terms of like the massive amount of work that needs to happen. And I think I'd like to tie that into the need to really start looking at our society and the resources that are available, because I think, even in traditional psychotherapy, there's a lot of moments, at least for me as a clinician, talking with clients where the pieces that are needed in order for people to get better have less to do with that individual going and doing something and more to do with the resources that individual has access to. And I think starting to sort of come down from the psychedelic trip a little bit and recognize that, there are some structural, we're dealing with some big structural issues that are contributing to the mental health crises that we're facing, I think can help make it less of a magical process and more of a process that is, grounded in reality. So yeah, hopefully that sort of goes off of what you're saying and synthesizes a little bit to it.
Yeah, I'm reminded of an analogy that I thought was really good, which was like, you may have heard it, like a fish in like a polluted river. Like, you take it out, you treat it with antibiotics, and then whatever disease it has goes away. But if you put it back in the river, it's just going to get sick again. And like, I think that to me speaks so much to the importance of like the whole context, when, especially, in many things, but in psychedelic therapy, I mean, it's super clear. And right now it's like, we're sort of moving towards this model of like dedicated spaces for psychedelic therapy that like potentially are divorced from context, and that's humongously problematic to me. Like, I see this, like the communal aspect of this is hugely important. therapists operating in this space need community. I mean, like we're all sort of collectively sense making around the subject. Nobody, yeah, there are, like you said, there are experts. There are people who have been doing this. Most of them are like underground. I think the people who have kind of emerged above ground and started doing this are like, it's in the last like 10, 15 years or something like that. But like for the rest of us, it's like, we're all kind of just like, like, what do you think? Like, there's not really much evidence to draw from here, and that actually brings me to another thing I wanted to say, which was you had on one of your slides about the guru dynamic around creating and utilizing treatment models without adequate empirical evidence, which is a really interesting point. And there was some fussing on Twitter recently about the MAPS protocol, because it lists a bunch of things in there that like an evidence-based, like, cognitive behavioral psychologist would look at it and be like, this is an evidence-based, what are you guys doing? It's gobbledygook. Personally, I love that stuff. Like the stuff that they're listing, like IFS, somatic experiencing, like I've personally gotten benefit from that stuff, but I'm not going to go saying that that's evidence-based psychotherapy. And at the same time, the evidence-based models we have don't really adequately explain what's going on when people are having these experiences. I mean, there's nothing in CBT about mystical experience, not that I've read at least. And so, yeah, and it's just, there's so much pre-verbal stuff that happens in psychedelic experiences that, sometimes I feel like some of these models that we have are almost operating at a different level, that they're sort of more intellectual or conceptual in a sense. And so, yeah, I wonder if you have anything to say about that, because like, there's not very good treatment models that have adequate empirical evidence for this. And if you use one that does have adequate empirical evidence, does it have it in this context? Yeah, that was kind of a big question, but
Yeah. So yeah, I think that's great. I think when we're talking about, for example, the MAPS protocol, I think the MAPS tries to accommodate the fact that there's going to be therapists with many different types of expertise, and the MAPS protocol really just invites for that variability in terms of, there are going to be different clinicians with different skill sets. And, I think they're banking on the idea that as long as the clinician has formed a therapeutic alliance, that, they're, whatever the client says, like, oh yeah, this technique or this, modality that you want to, offer me, I really connect to that, that will be helpful. So, so I think there's that part. In terms of, when we talk about like evidence-based, I mean, I think I'm referring less to like the need to use CBT and just more like there isn't any evidence that psychedelics are actually, like we don't have evidence of how psychedelics are useful, in what context, and we don't have generalizability for the use of psychedelics specifically. So, in terms of what therapeutic modality is used, when you combine that with psychedelics, I mean, we're not even there yet, right? So that's kind of the thing that I'm trying to point at, is that like, we're just starting to gather evidence that psychedelic drugs can be useful to some people in a therapeutic context. Now, how they're useful, why they're useful, what maximizes their benefit, we don't have those answers. And that's what I'm saying, is like, we're lacking evidence for those facets. And then, in terms of like, we still need to do research in order to understand, well, what kinds of eclectic approaches are going to be well suited. I mean, I would agree with you. I love IFS. I love somatic. I'm really oriented towards somatic work and IFS work. I utilize components of that in my own work with clients, and I've received lots of therapy, in those modalities, which I found incredibly useful. We have to figure out, well, what components of that actually fits in with, psychedelics. And then, also there may be other modalities that are much better suited for prep and integration work, and those may be more cognitive. Those might be more, of an ACT or CBT model. So that's where I'm saying is the research still needs to be able to test these things, because like you're saying, we can say like, oh, IFS is like, that sounds so psychedelic, that must be it, right? And so somebody could kind of operate on that assumption, and it may help a lot of people, but we also don't have, the data and the evidence, and we haven't really been able to test this hypothesis. So I think like any other treatment, I think we need to recognize that, this is a major limitation. And if people are offering psychedelic therapy, there has to sort of be this humility that like, we don't actually know for certain anything here, and this is still in progress, right? So I think acknowledging like where we are at in that process, and I think focusing more on, well, what are the core clinical skills, what are the core competencies, what are the core pieces, that I need to have to be prepared to utilize, psychedelics in practice. And really, it's not until you've worked in mental health for a long time that you start to understand how and why psychedelics could be useful. If you haven't had much experience working with clinical populations, then it's very easy to just assume that psychedelics can be inserted anywhere in therapy, because you just haven't really seen a lot of it, right? So yeah, hopefully that's helpful in answering that question.
Very much so. So we're about at the hour. I don't know if we want to open it for maybe one more question, or if you have to run, we can also just close up shop. But,
yeah, I think I have space for one or two more questions. I see like Rebecca and Danny are in here. I haven't heard from them, so I wanted to see if they had any thoughts or questions.
I guess I was wondering, why do we need evidence? Like, if we know it works,
Do we know it works?
maybe we don't.
We don't know it works. I mean, that's really the lack of evidence. We don't know it works. It has been helpful for some people. We can say that, but it's not 100% effective all the time, right? And even in the clinical trials with psilocybin or MDMA, there's a sizable portion of people that either, number one, didn't report that it helped them, or number two, like actually felt like they got worse afterwards. So to me, that, we haven't been able to explain those things. We haven't explained why, why didn't it work for this person? Why did this person get worse? So yeah, that's a good question. But yeah, well, how would you define knowing that it works?
I mean, I think that sometimes with our field, a little too much emphasis is put on this kind of science that is shaped after hard sciences. I'm not saying that evidence is not important. I definitely think it's important. In fact, I'm a little bit more in the like CBT side of things, theoretically, but maybe we're using the wrong kinds of evidence.
Yeah.
Either way, we need like fewer restrictions and more money so that this kind of thing can be explored, because as you said, for some people it is really helpful.
Yeah.
And why is that the case, and how can we make that the case for more people?
Yeah, and I think like one thing that I like as you're sharing that, like one thing that I sort of think about, from a clinical standpoint is like if there's a person who really feels like using mushrooms is going to be helpful for them, like I think as a clinician, um, I think, there's space to support that person in that exploration, right? Like, not to be like, well, there's no evidence, so don't take mushrooms. I mean, I think that, it's like, hey, like this person, maybe they read the research and they're like, hey, look, like, I've been depressed for a really long time and I want to take mushrooms and I want to talk to you about it, right? Like, as a clinician, I think it's perfectly, within your scope to say, yeah, like, maybe I can consult with someone who has more experience with this. But, I think that that's a great opportunity to, like you said, I mean, trust in that inner knowing, right? Like that isn't really based in evidence-based practice, or it's not based in science necessarily, right? There's not a direct observation, but this individual feels like it's the right thing for them, right? And I think that coming from the client, I think it's a very different dynamic than if the clinician is advertising, right? And I think that's my sort of soapbox with pushing this idea of evidence-based. I think it does need to be evidence-based if you're marketing. If you're out there saying, I offer this therapy, right? I do psychedelic therapy, then there needs to be evidence and there needs to be, research so that that person can be fully informed in their practice, right? Like what is informing your decision? What's your decision tree and how is your decision tree done if you're administering, right? If you're the one saying, I think psilocybin is for you, or I think MDMA is for you, right? Then that creates that power dynamic. I think it's very different, maybe this is different from what you're saying. So do correct me if I am, making an assumption, but I'm also sort of feeling like there is space for, for a client to say, hey, I think this is really helpful for me, or, I did MDMA with my friends and I experienced something really good, and to as a clinician to really support that and to be like, hey, let's talk about that. Let's use this relationship to further explore that and support your process, right? So so does that make sense? Does that hopefully that offers a middle ground and not not such a rigid idea that everything has to be evidence-based, yeah. How is that more in line with what you were saying?
Yeah, I was just playing like a little bit of a devil's advocate, like why do we need any evidence at all? Because I do see a lot of value in evidence, and you did help clarify for me that like if we can figure out like the mechanisms of what makes it work or the qualities of patients for whom it will work, then it can help us decide when and how to use it.
Yeah, and hopefully more it being more about how is one making the choice or making the decision, right, to prescribe this sort of thing. And I think that's more what I am hoping to impart is like having adequate training and experience to make those kinds of suggestions and decisions, that that doesn't compromise someone's safety, and hopefully that can be better. And I think there's a lot of it's a very attractive thing to say, I do psychedelic therapy, but the question is like, what does that mean, and what is your training? What does that entail? And I think there's a very big difference between, I can watch you and make sure you don't hurt yourself while you're on drugs, and being a therapist and actually doing therapy, and understanding like how the therapeutic process is affected by, altered states. So I guess that's where I want to introduce a bit more caution and, sort of critical thinking around that. But I think it also is important to push back and think like, I agree. I want to see community and, individually oriented things. I don't, my vision is not like giant pharmaceutical companies telling us how to do therapy. That's really not my vision. I really do think like, a community oriented and relationally oriented process is best. And for clinicians to be well educated and for clients to also be well educated to make these collaborative decisions about, is a psychedelic appropriate? At what point is it appropriate? Do we both have the resources to do this well? That I think that's the ideal thing. So yeah, I really appreciate that. And I hope you continue to, to ask those questions, because I think it, that really does tie in with some of the bigger systemic pieces that was part of this original presentation, but I didn't, this one I focused more just on therapy. But yeah, thanks, Rebecca. Appreciate it.
I think that's kind of an interesting point about if you are sort of prescribing something like this, that there is a sort of burden of evidence that's on you. That's just like, well, if you're selling this, what is the evidence you have that it's going to work? I mean, on the other hand, it's like, the universe didn't need evidence to start growing psilocybin mushrooms out of cow dung, all over the world. Like, so, I feel like there's sort of a disconnect there between like the policy around what are people allowed to do, and then like the policy around what are like providers allowed to do. Like we shouldn't need evidence to say that people are allowed to do this if they want to do it. But here we are, the burden of evidence is on us to say that it helps for X, Y, and Z before people are allowed access.
Right.
So that's
I would argue that we need to, I would argue that we need to separate out these two things. Like one is like decriminalization of substances. Like that is a totally separate conversation from the use of psychedelics for therapy. Like they are totally independent. And I really think that people need to argue for that difference. Like the decriminalization is that argument, in my view, is that no drug should be, the use of any drug should not put you in jail, period. That's a very different argument from how do we make certain drugs available for the treatment of illnesses, right? And that's where I think, yes, we do have the burden of evidence. We do have the responsibility to do no harm. And we do need to make sure that we're not doing things that are going to, to hurt people. Because that is, that's what we're being faced with, right? Like that's what this specifically in therapy, that's the danger that we have. I absolutely think that, people should be able to use any drug that they, that they feel like, okay, this is the drug I want to ingest, right? I mean, I think it's more about like what substance is being used for a certain purpose, right? And then we get into, is the substance being used appropriately, or are we abusing a certain substance, right? When we talk about like amphetamine to treat ADHD, there is an appropriate application of that. And there's also an abuse of that substance where, an overdose of amphetamine is not going to be therapeutic and actually can be harmful, right? We know that. So I think psychedelics in the same way, right? Like, and I don't think anyone should go to jail because they want to use amphetamines or whatever. So I think hopefully going forward, we can also start to separate those conversations where we can be part of the larger movement of, decriminalizing people who use drugs, and then also, continuing to advocate for, safe directions forward.
Very much agree.
Well, Yeah, I'm open to one more question if people have any burning questions, but yeah, just thanks for this opportunity to talk about this.
Thank you, Rafaelle. This was really wonderful. Lots of food for thought. I know this was sort of just sampling like a ton of different issues that we could just dive in and probably talk all day about, because there's just so much here. It's really complex stuff. I'm really glad you're doing this kind of work and trying to parse sort of the different elements of ethics in this space, because wow, is it so useful to have people thinking clearly about it. It is sort of a frontier. So very much appreciate you joining us. This was really awesome.
Oh, yeah. Well, thank you so much for having me and listening to my unpopular opinions. Yeah, if you have any questions, or if you ever don't hesitate to reach out. That's my contact information. And I do offer like free meetings with students. I really I want to support students in their process, so so that's available. And I do have pretty low rates for any sort of like clinical consultation or anything like that. So yeah, and regardless of any of that, please don't hesitate to reach out. Like, I want to be a resource for people. I don't want, this isn't about money for me. I want to make sure that people can have these conversations, and like, I want to create community and collaboration. So yeah.
Awesome. Thank you. And thank you for joining.
Yeah, thank you so much.
Thank you.
Really
Excellent.
nice.
Take care, everyone.